Okay, so ladies and gentlemen, now that you have done the toast, or otherwise known as the yum saying, at this point of time, we're glad you're soaking in the festivity this evening. Now, one of the highlights is for tonight, the debate. That's right. So, ladies and gentlemen, debate one will soon commence. So, without further ado, before we start that segment, we also want to again have a gentle reminder. Of course, throughout the evening, we do hope to see your beautiful and handsome faces. So please make sure the videos turn on, okay? That's something that we really want to see because hint, hint, it's gotta do with a very, very important part of the evening later on, okay? So don't say we're not telling you, but your video is gonna be important for a later part of the evening. All right. So, ladies and gentlemen, the evening debate will now commence. And of course, in order to do so, allow me to invite back once again a very busy man for this evening, Dr. David Tan, who will be moderating debate one. Dr. Tan, please.
All right, thank you. And please do not be sick of my face. Please do not switch off or block off my face. I promise you, this is the last time you're going to see me until the end of the dinner. Okay, so my role now is as the moderator of motion one of our debate. And we are going to begin our grand proton therapy debate this evening. Well, as I mentioned before, this promises to be a very exciting debate. I believe I haven't seen anything like that in the region, at least, or everywhere, a debate where we have speakers sparring with one another from both ends of the fence. And mind you, I to be honest, okay, I haven't looked at all the videos. They have been pre-recorded, but I have to say, looking at snippets of them, some of that, the debates can be quite fiery and they can be quite yum sing, in my opinion, right? So they can be very, very feisty. Let's brace ourselves to hear from our experts today. Now, a brief introduction as to the format of today's debates. We will have a motion, okay? And the motion one, what better way to start our proton debate with the motion that proton therapy will be the standard of radiation care in the future. A very provocative topic, and we look forward to hearing from our two speakers. We will have a proposition and an opposition from both sides of the fence. Okay, and we will start off with both speakers delivering an opening speech, or what I would call an opening salvo, which will last 6 minutes each, following which we will then listen to a rebuttal from each of the speakers on their counterpart's speech. So basically what has happened is that the speakers have recorded their speeches once, and then we have exchanged speeches and sent their counterpart speeches to each speaker to then watch and to prepare a rebuttal. So that will be the second segment of our debate, where we have each speaker rebutting for 2 minutes and summarizing their viewpoints, following which we will then open up to the floor for 5 minutes of interaction between all of us present. So you can feel free to type your questions in the chat group and or also to unmute yourself and ask questions, right? And what's more, the speakers will not only be here in spirit, they will be actually here present with us in this Zoom meeting live. We have already seen Professor Das and Professor Hoyer with us and watching the show. So they will be here to answer all your questions in the final segment of this debate. Right, so let's begin by hearing the proposition speech from Professor Das. His biographies, okay, speaker biographies have now been posted on our website. You can look at the chat group, you can open the link and you can read a little bit more about them. So just allow me to give a brief introduction to Professor Das as he begins his speech. Dr. Das is an internationally acclaimed medical physicist with expertise on radiation dosimetry, small field dosimetry, treatment planning, MRI, LINAC, and proton beam therapy. Dr. Das has worked in major academic centers, University of Massachusetts Medical Center, Fox Chase Cancer Center, University of Pennsylvania, and the NYU Medical Center. He has published extensively with over 200 to 300 papers and books under his belt. And he's currently serving in the editorial board of the IGROBP and the Journal of Medical Physics. So without much further ado, let's welcome Professor Das as he delivers his first opening speech for the motion proton therapy will be the standard of radiation care in the future.
Welcome from Chicago, and thank you for inviting me. I hope you guys have a nice dinner. I wish I was there. So let's talk about this debate about the proton. A very good article just got published in JSEMP. It's talk about the same issues we are talking about, the pros and cons of proton proton beam therapy compared to the photon. Our cardinal belief is that the maximum dose should be to the tumor and minimum dose to the organ at risk. Dose distribution should be based on the deviation. Particle beam has certainly advantage in terms of range. And if the dose is a surrogate, then proton is a winner, which is not a questionable. But if that is the case, why it is not translated? Well, it's because the technology, know-how, and cost. Now, looking at the dose distributions for a single beam, everybody knows that photon beam has attenuation properties, whereas the photon beam has a finite range. So looking at the dose distributions, you can see that SOBP gives uniform dose and lower dose to the skin. When you look at it in parallel opposed situations, you see that photon beams gives a very high dose to the sides, and proton beam gives lower dose on the sides and highest dose in the center of the tumor, which is what was desired. Looking at the pictorial for the dose distribution, this paper is from Boston. Photon gives a uniform, not uniform, but it uniformly irradiating the whole body. Electrons, the partial body, and protons, it's only to the spinal cord for this pediatric case. Looking at the dose distribution, if you put the proton beams 3D and in the head case, you can see that we can spare all the critical structures in the proton cases. Looking at the breast, you see that photon, it provides a lot of dose to the contralateral breast and dose to the structures of the heart, whereas in a proton beams, we can actually spare all those aspects. You see there is no dose to the critical structures. Looking at the SBRT, the same, you see the whole body dose here, and in proton, there is no dose. This has been summarized by Professor Langendick in terms of the TCP and TCPN outcome, and he concluded that proton beam has a better theoretical outcome. We provided the data for the intensity modulated and why the technology is not there, and some of the aspects I'll discuss with you here. So in IMPT, we need to know about the range uncertainties, robustness, algorithms, spot size, energy switching, dose rate, imaging, motion management, RB, and clinical outcome. The cost factor, you can't read all these things, but here is the fact, is that carbon to photon is 4.5 and proton to photon is 3.2, which is significant. Limitations are that uncertainties in physical and biological uncertainties are significant, and we need to know that. Spot size is a big problem. Energy switching is a problem. Imaging in room is a problem. Respiratory motion needs to be addressed. Algorithms needs to be addressed. And cost. Cost is significant. The machines, the manpowers, and operational costs of these machines. Looking at the secondary malignancies, this data provides very good information about the modalities, VMAT, proton, IMRT, and 3D. And you can see that the proton beams have the lowest probability of the secondary cancers. So take-home message is the proton beam is a fast-growing treatment modalities, complex and costly. More research in productions, planning, and motion management needed. Imaging tools, proton radiography, and a lot of things are coming up online. Better PR in community and clinical outcome data to convince critics. And thank you very much. This slide was taken at your hotel in the front of your garden. And I want to take some questions. I'm sure that we will have the lively debate. So thank you very much.
All right, thank you. I'm still trying to chew and finish my food. But anyway, thank you very much, Professor Das, for your opening speech. And what we have now is to hand over the time to Professor Hoyer, who will then give his opening speech as the opposition for the motion Photon therapy will be the new standard of radiation care in the future. Just a very quick introduction of Professor Hoyer, who is a friend of mine. He is Professor and Medical Director of the Danish Center for Particle Therapy, and he specializes in radiation therapy of brain, liver, prostate, bladder, and childhood cancers. Professor Hoyer is very active in the ISTRO and IAEA scene, and is currently establishing an educational and training program under the European Network for Particle Therapy. So without much further ado, let's invite Professor Hoyer to give his opening speech.
My name is Morten Højer. I'm the medical director of the Danish Center for Particle Therapy. Thank you very much for inviting me to this debate. During the next 6 minutes, I'll try to argue that proton therapy will not be the new standard of care in radiation therapy. I know that you're sitting at a very nice dinner. Do I have a difficult task then? Absolutely. And even I'm a great fan of protons. Why is that? That's because of the very good dose distribution we have with protons, where we have less dose before the target, no dose after the target, and even a very delicate way of delivering the dose. Do we have the evidence for protons? Unfortunately not, at least not yet. There are even randomized trials on protons contra protons. It's one example is this one in inoperable non-small cell lung cancer, randomizing patients between passive scattered protons and modern IMRT protons. It failed to show that it's an advantage when it comes to radiation pneumonitis. There was the same local control in these two arms. It doesn't necessarily mean that there's not an advantage of protons here, but it just shows you that this study, which was conducted at one of the expert facilities, did not show a difference. And it shows that it's extremely difficult to conduct such a trial. There are a lot of planning studies showing an advantage to protons over photons. This example is from Denmark. It's in breast cancer. And it shows that you can have a very good coverage of your target, the breast and the IMN, and even with a very low exposure of the lung when you use protons. So there is an advantage, but is this a proof of protons as a preferred treatment? No, it's not, because we don't know if this translates into meaningful clinical outcomes, such as reduction of cardiac events and reduction of risk of secondary cancer. And beside that, the robust protons are less robust. I'm sorry, the light went off. It's here again. There are day-to-day variations in the patient, motion during the treatment, air cavities that can be filled and empty. And then there are range uncertainties in the way that we calculate the dose on our treatment planning systems on the CT scans. And there are RBE uncertainties. I will just look a bit on that, because there's a conversion between photons and protons. Protons are 10% more efficient, so there's a factor of 1.1 when we calculate the dose. And the problem, there's a large distribution of these studies that were used. They were experimental studies for this conversion factor. And this means that there's some uncertainty here. And it could be 5% larger, most likely, or it could be even lower. And it depends on the dose and fractionation, tissue type, and even the position in the beam. This is the position in a beam thing, because at the end of the Bragg peak, there's strong evidence that there's a higher biological effect here. This is because of the increased density of ionization in the end of the Bragg peak. And there's also some clinical evidence that this is the case. This is one of them, showing changes after treatment with protons in patients where you didn't expect it if you looked at the physical dose distribution, as is the case here. But if you looked at the LET weighted dose distribution, the biological kind of dose, and combine that with a higher sensitivity in the brain tissue close to the ventricular area, then that can actually explain why we see these factors. So we believe that there's a need of studies and that patients should be treated as part of clinical studies when we are using protons. These are the studies we are running now in blue. The green are those that starts within a few months, and the red is one that we have in a planning phase. So my conclusion is, and I'm sorry I didn't show it to you, I didn't have the time for it, that there's obvious advantage for protons in children because of the reduced risk of morbidity and secondary cancer. But there's still a need to have more evidence in adult patients. So my conclusion is that proton therapy will not be the new standard of care in radiation therapy in the near future, but hopefully in the longer run. Thank you very much and enjoy your dinner.
Thank you, Morten, for the very interesting talk, and Professor Das as well. We move on to the second segment of our debate, and I'll not hold you back any longer as we now move on to hear Professor Das's rebuttal of Professor Hoyer's opening speech. So, Professor Das, please.
Thanks, Professor Martin Hoyer, for very interesting observations about the randomized trials, outcome data, and know-how about the technology and radiobiology. So just to end the rebuttal, I am going to provide some facts about the outcome. Professor Weber from PSI, he provided the data indicating that chondrosarcoma sarcomas with a proton beam has a very high outcome, as you see from this data. Similarly, for HCC, if you look at Japan, the data indicates that it has a superior. Now, in the case of breast, you see that the data here indicates that. So there are, in every disease sites, we know that we can do far better job. Now, question is that clinical trials, these were written in 2007, and there is a lot of data available. Obviously, people blame these data to the media and ourselves. The next was that Herman Soot, when he talks about the clinical trials, and they felt that there should not be any clinical trials. The reason is that we don't need randomized trials between a kilovoltage and megavoltage and any other modalities when we know that it's a superior. So thank you very much, and I can take any question.
All right, thank you, Professor Das, for your rebuttal. And now we move on to hear Professor Hoyer's rebuttal of Professor Das. So, Professor Hoyer, please.
Thank you. And thank you, Professor Das, for your presentation. It's, I think we agree on very much of what you said. And I think we all believe here that protons are superior to photons in many cases, in many patients. What I say is that we really also need to show it in clinical trials. We know from comparative treatment plans that protons are often better than photons when it comes to dose distribution. But what we can really spare is a low dose volume, not the high dose volume. I think it's important to say, because of the issues that we have with protons, it is just not another type of X-rays. So for that reason, ladies and gentlemen, I really recommend to start up doing proton therapy as part of clinical trials so that we can convince everyone that it's the right treatment for selected patient groups. Thank you very much.
All right, thank you to both speakers for their wonderful presentation. We were having some comments that this debate is still quite civil and quite respectful. And we are thankful to the speakers for giving us a nice mellow start to the evening. But that's not all there is for today yet. There's still an open session where we will invite our speakers online once again to take any questions from the audience. So let's invite Professor Hoyer and Professor Das online with us.
Yes, I'm here. Can you hear me?
Yes, we can all hear you. I'm Morten. Good to have you with us, and thank you for taking
Good
the
to see
time
you.
to join us. Yeah. Okay, so we're going to open, and I'm just waiting for the screen because there is a layout where we will have both speakers online as well. And basically what we're having here is some questions, some comments on the chat group, actually just one. But let me just read out what Dr. Brendan Chia has raised as well. He says that after hearing your speeches, it seems like once we get past the steep learning curve, protons will be superior across the board. So this is a comment from our audience. Any thoughts from our esteemed speakers today?
Well, I can talk to you about the know-how or the experience is very critical because proton beams are very complex. There's absolutely no doubt the protons are superior than photon beams. And when it comes learning, I think your person who asked the questions, he had a very good understanding that it's a complex problem and we need to know how this technology works. So I think I respect Professor Hoyer's comments, but it's just because we don't know how to use the proton beam.
Yeah, I really agree with you. It's right. There's a lot of things that we should learn to utilize better. We have, I mean, the dose distribution is really superior in many cases. I think I think and I think you also agree with me. There's a lot of places where we can still use photons with the same kind of outcome that we can get with protons. So our task will be to find the right patients for the right type of treatment. I think it's important that we will see some trials that can really confirm that there's the reduction in dose, that what we can see from those volume histograms translate into clinical outcomes, reduction of morbidities. I think that is extremely important, at least here in Denmark, to ensure a sustainable referral of patients to our center. This is the way that I can convince my colleagues in the oncology centers to refer the patients here. And I think this is what we are struggling with in a lot of centers. We need to prove that the reduction in dose to the lowest dose, intermediate dose volumes translate into meaningful reduction in morbidities. We might not need it for any tumor type, but we just need to show it. For instance, in head and neck cancer, also in lung cancer. I'm really so. I'm really. It's a great. I mean, loss for me that we did not see it in the lung cancer study that I just showed you as an example. There's a lot of explanations for it.
Thank you both for your comments as well. I just want to raise another question. I took a bit of time to try to understand it, but I think I get it now. The question is a little asked in an indirect way: is there an advantage of driving a Ferrari on a 60 kilometers per hour road? Is there an advantage of driving a Ferrari on a 16 kilometer per hour road? And of course, there have been some discussion, and someone has said you do that to get admiring looks. So anyway, yeah, that's the view of the audience and the discussion that's going on. Any comments from our speakers?
Very good question. I think that I agree that you don't need a Ferrari, but the status and look, I think, as you mentioned, is a good thing. So, but you never know whether the road will be 60 kilometers or it may be 100 kilometers. So you have no idea. So I think I would not just discourage you not to drive on that. As you pass that 60 kilometers zone, you know, you may be faster and you may enjoy the ride.
Exactly. I mean, a Ferrari is not good for off-road, but definitely it's a. I had never been riding a Ferrari, but there are. I mean, you have the right car for any purpose. The same
Yeah.
with X-rays and protons.
Thank you very much for both speakers. I just want to give one final question. And I think the last few questions in the floor is pretty much summarized in the question by Dr. Bala. And the question is, protons have been around for a good 10 years. Why has it been so difficult to generate the evidence? Any thoughts?
Well,
Yeah.
well, I think the problem is that it's expensive, and most people, they want to treat patients. They don't want to publish data. That is the sad part. I agree with the Professor Heyer that we should publish. We should publish, but unfortunately, because of the cost associated with that, people are discouraged. So I would strongly suggest that uh, it's not because we don't have the data. We just have not put our mindset to do that, and I think we should. And I again thank Professor Heyer for interesting, and we both agree on the same thing. It's just a small minor differences. Thank you.
Professor Hoyer, your closing
Yeah,
thoughts.
I agree, and has been really enjoying listening to you, Professor Das. I think there's one thing here. It's not a great business case to do randomized trials because you need to convince a patient to go and you have to tell about pros and cons for entering a clinical trial. And some patients actually end up getting the photons and not the protons that you are testing as a potentially better treatment. It's much easier to say to a patient, I have this better type of radiation therapy and you can have it. And even here in Denmark for free. So it's much easier to treat patients outside of a clinical trial. But I think we must do it in some cases. And here it's one of the tasks that we have to do clinical trials and to introduce protons as part of clinical trials. And this is what we try to do.
Thank you very much, Professor Hoyer, for the comments. And I think you raised a very important point. I mean, there was an issue about economics, and if the treatment is free and it's better, potentially better, why not? And I think we look forward to the second debate as we discuss a little bit more about the economics of proton therapy. But let's leave it as such for now as we move on to our next segment. Once again, a very big thank you to Professor Das and Professor Hoyer for gracing our event. And we greatly appreciate your inputs and your scientific rigor in this debate. Thank you very much, and we'll hand the time back to our MC.
Great rendition of I Will Survive and 刻在我心里的名字 by Dominic and the band. As of now, ladies and gentlemen, again, we hope you've been very fine in this beautiful evening, and we shall now proceed on with debate 2. Now, with debate 2, we will have Dr. Daniel Tan as the moderator for debate 2. Ladies and gentlemen, may I now pass the time to Dr. Daniel Tan, please.
Hi everyone. Thank you so much for organizing this, and thank you MC and Dominic and Ben for warming us up. And we are now entering into our second debate. I will read to you the motion, and then after that introduce to you the speakers. Motion 2 is entitled Clinicians should focus on translating the best science and technology to clinical practice and not be burdened by health economic considerations. Clinicians should focus on translating the best science and technology to clinical practice. Clinicians, right? And not be burdened by health economic considerations. Now, as a trainee and growing up in an environment that has seen a lot of change, with a rapid uptake in all sorts of technology-assisted innovations, we have seen what we can call seismic shifts of opinions, ranging from a almost nihilistic type of approach to treating any patient with metastatic disease, all the way to the other extreme, whereby almost experimental treatments are given as a last-ditch effort to save them. So now, obviously, this doesn't directly translate to proton therapy, but it centers on issues discussed in this motion. And so I think the idea is for us to dig in and back to our own experiences and listen to the speakers and see which side resonates with us. A quick introduction to our proposition speaker, Dr. Chua Yu Tiong. He's no stranger to us. He is a mentor to many of us here and has held headships and presidentships in societies and so on. But at the heart of it, he is a passionate clinician, and he will be sharing with us his views as the proposition. And I'll introduce our opposition speaker later on. So Dr. Chua, please.
Good evening. The moment God gave us the concept of free choice, we have placed a value proposition upon the act of choosing one or the other. It may not be monetary value, but other values such as ethical, moral, pleasurable, or even collective societal values. So the first premise is we cannot divorce ourselves from value while we choose to accept or to provide treatment. The topic is clinicians should focus on translating the best science and technology to clinical practice and not be burdened by health economic considerations. If you look at the highlighted parts of the debate motion, you will see several issues. The first is focus. It means the clinician's job is to put his main effort in his work, and that is translating the best science and technology to clinical practice. It cannot avoid the judgment completely, but the focus is definite. The second is the word best. It means best in its scientific merits without the cost element. Finally, the term burden can mean different things to different people. It would imply that there's some, but not burdensome, health economic considerations. The presentation is divided into two parts. The first focuses on how the clinicians are involved with translating the best science and technology. The second part of the presentation is to reveal the pitfalls of health economics, and there are compelling reasons why clinicians should avoid getting involved. Let us start with the first. When clinicians translate the best science and technology, they're delivering this through the whole entire gamut of clinical management of the patients, equipped to deliver the best treatment. Think about the ethics involved. Continue to gather accurate data, educate others and oneself. We are down right at the bedside. Let us take a quick look. 1. Concentrate on developing and delivering better treatment resulting in better survival and, of course, less side effects. 2. Assess the ethical implications of not offering and over-prescribing the best treatment. Leave it to the health economists to deal with it. In real life, the clinicians have to bear the brunt of this issue. They have to explain why a particular treatment cannot be given because of costs. Much time has been and will be spent in the clinics explaining, a job the clinicians have to manage, having already cultivated the doctor-patient relationship. If only this can be left to the authorities of health economists to tackle. The ethics of overprescribing and overselling is another area. 3. Clinicians should look into educating colleagues in other medical fields, administrators, and the public on these treatments. Fake news is a flavor of the moment. Educating the public comes in several ways. Besides accurate information of the use of the treatment modalities, there is the issue of perception. The more expensive the treatment, the better it should be. A very real perception fallacy that needs to be addressed. Expectations should also be managed through education. 4. Do good work and collect data. Here, the authorities must see the value in providing enough personnel to accurately collect the data, both for healthcare allocation as well as to have accurate input for analysis in health economic models. Survival and side effects data require long-term and sustained funding, sometimes into several decades. 5. Be prepared for the future of personalized treatment, such as genomic profiling and selection of patients that will benefit. Even explore studies like barcoding of cells as a means to identify specific cell groups to target. Now we look at the pitfalls in health economics and health economic models. Let me just give you a real-life example. In the early days, as far back as 2006, we had to write papers to present to the authorities controlling the purse strings for setting up the Proton Center in Singapore. As the economics of setting up the center depended on many factors, in writing the paper, we had many assumptions on data collected to create a situation in our favor, and of course, that similar data could be used by the opposing camp to deter setting up the center. A yes minister situation arose. Depending on whether you want it or you do not want it, the data can be used in different ways. First, patient numbers. The more patients that are treated, the lower the cost per patient. So we included all private patients that are liable to be treated in Singapore, summing up the numbers from both the public and private centers. Whether this will really happen, we do not know. We made that proposal on the assumption the science was so good that no one will be treated by any other means. Then one cannot divorce the cost of setting up the center in computing the cost per treatment. This is especially so in land-scarce Singapore. In fact, the authorities proposed setting up the center in a far corner of Singapore rather than in the vicinity of the Pinnacle at Duxton Plain, which is near the Singapore General Hospital. The Pinnacle was probably the most expensive public housing then. Of course, we were horrified by the proposal. Sure, the cost will come down substantially, but it will be setting it in the midst of some secondary jungle away from any medical activities and facilities. On a more serious note, specific disease health economic models are fraught with problems. Are economic models adequately addressing questions relevant to oncology decision makers? If the data used is inadequate to represent the disease states or the patients, for example, they may be from clinical trials alone with specific entry criteria. Are the economic modeling making too many generalizations to fit the models? What are the guidelines available so that they can even be comparable between users or countries? What is quality adjusted life year? When the quality of life data collected is not individualized and changing even as you treat. Finally, has the modeling kept pace with treatment innovations, or that the individualized treatment is becoming the norm? These are just some of the issues health economists grapple with. So clinicians leave this out of the busy schedule and concentrate on delivering the best treatment. Hence, the term health economics in the proton-photon debate is perhaps misplaced. The topic should be more crudely but honestly stated as, should clinicians implicitly will dispense the best treatment, worry about patient paying the bill, and hospital recovering the fixed costs when it comes to choose proton versus photon therapy? Conclusion. When I was asked to propose the topic, the organizers must have thought I was a socialist and would ignore costs. Truly, I'm more a capitalistic socialist, or more correctly, a socialistic capitalist. To be truly socialist, I would be in an utopian society where costs play no part. Nevertheless, even if costs do matter, clinicians must not be burdened by cost considerations while they devote their minds and energy to producing the best for patients. By doing so, their efforts and undertakings will improve lives and even, well, reduce costs in the long term. Thank you.
Thank you, Dr. Chua, for so much information compressed into 6 minutes. The next speaker is Dr. Matthew Callister, a new old friend over the past few years, who is a seasoned clinician. He trained in Mayo and then went on to serve in Banner MD Anderson's new setup and built it up. And then, like many esteemed colleagues in Singapore, moved on to administration, becoming the medical director of Banner MD Anderson Cancer Center, and subsequently senior physician executive. And over the past few years, he has moved his family to China and is now Chief Medical Officer of Concord Medical Services, being in charge of their proton therapy project as well as their 3 cancer hospitals. So he will share with us his experience and views as the opposition from the perspective of a clinician with administrative experience. Dr. Callister, please.
Dear colleagues, good evening. I so appreciate this invitation to participate in the annual Singapore Radiation Oncology Dinner Symposium. I truly regret that I can't join with you live at the events or be in person due to international travel over the holidays, but I do look forward to watching this event in the coming days by recording. First, let me acknowledge to you that I do feel that clinicians have the central role of judging the advancement of new science and technology and its application into clinical practice, and truly believe that clinicians are the only ones that are really able to capably judge the importance and value of these new emerging techniques. But at the same time, I believe that economic considerations are well within the scope of physician decision-making and should not be completely relinquished to others. I suppose there are good reasons that clinicians should remain engaged in issues regarding costs from many different perspectives. We should have a voice in the distribution of society's limited resources and in our efforts to promote health equity for all. We should certainly be involved in what is an emerging toxicity of financial toxicity for patients and looking for solutions. But there's two issues tonight I'd like to mainly emphasize with you. First of all, that as clinicians, frequently we do not know enough to advance new technology and treatment based on scientific evidence of efficacy alone. What do I mean by this? In an ideal world, the clinical implementation of new technology and treatment will be solely based on complete high-level evidence from prospective randomized clinical trials that are reproducible and can be broadly applied to all relevant patients. In reality, however, we know that as individual practicing physicians and as institutions and societies, that often we have to admit that the level of high-level evidence that we want is not sufficiently there to judge new technologies or emerging treatments. Prospective randomized trials are often inconclusive or have not taken place. Retrospective studies often suffer from bias, reproducibility, or have conflicting results. In our individual clinical practices, we're constantly having to struggle with patients who have diagnostic or staging uncertainty and may very well not have been included within the inclusion or exclusion criteria of studies. We see patients with rare and uncommon diseases that have been understudied. So what I'm trying to say is that in the absence of pure evidence from the scientific method regarding efficacy, we naturally have to apply imperfect judgment from a variety of perspectives and sources that includes financial issues as well. In this setting, we need to broadly include efficacy, safety, quality of evidence, consistency, and economic considerations. Secondly, I would propose to you as clinicians that if we do not engage successfully in cost-effective considerations, others will do this for us. The reality is that resources for healthcare are fixed, and to some degree, obtaining them is competitive. Decisions and judgments will be made, and so we need to stay engaged in this topic, particularly at institutional and society levels. I'll point out as a solution or a direction that I think is encouraging to us that we should follow as radiation oncologists. The NCCN publishes not only practice guidelines, but practice guidelines that include evidence blocks for most of its diseases. These evidence blocks are a 5-point scale that cover 5 dimensions, not just efficacy, but also safety and toxicity, quality of evidence, consistency of evidence, and financial affordability for each drug treatment regimen. A similar system for radiation oncology I'm not aware of, but I think it would be very helpful as we continue to engage in emerging techniques and technologies, which certainly often are expensive. Moving forward, I favor that as clinicians, we continue to strongly engage in cost-effectiveness considerations, so that we can have a voice in determining and calculating this imperfect but critical equation of value. Who does this? How do they do it? I suppose in our goal to support the individual practicing physician and the patients they serve, we need to continue to align and define our judgments at institution and society levels. Thank you again for your time, and I look forward to hearing more about this important topic.
Thank you very much, Dr. Callister. again, packed with many nuggets of truth. And you may have started off citing one side of the motion. Now I think you might be a little torn. So let's move on to the rebuttal, starting off with Dr. Chua and his 2-minute rebuttal to Dr. Callister's speech. Dr. Chua, please.
It is certainly an insightful presentation by Dr. Callister, who rightly pointed out that clinicians should literally not cut themselves off from financial considerations in delivering treatment. They should have a say, and they are the best people to do so. However, the organizers of the debate have left me with a way out of this situation by using the terms focus and burden. Both of these terms imply a certain amount of leeway from the extreme. While it is true clinicians should be the best people to prescribe or recommend treatments, bearing in mind the limited resources, the issue is one of extent of involvement without being burdened by such considerations. When a clinician is bogged down or burdened by financial considerations in medical treatment, he loses focus in his primary mission, which is to deliver the best science to his patients. Many clinicians are involved directly or indirectly in the collection of meaningful clinical data, in examining the ethics of treatment, whether in giving or withholding, acting as patient advocates and collaborating with others and in educating themselves. The science of health economics gets very complicated with mathematical modeling. You really do not want a clinician to be embroiled in health economics. Instead, we should leave a certain amount of mystery and ambiguity to this branch of economics. A medical specialist with deep involvement in health economics on the other side of the fence, the administrative side, may end up being a hindrance. As it is well noted, where you stand depends on where you sit. So just continue with the science. Your involvement in health economics will come indirectly. Thank you and Merry Christmas.
Thank you. Merry Christmas, Dr. Chua. Still torn? Well, let's hear from Dr. Callister and his reply. Dr. Callister, please.
First of all, let me congratulate Dr. Chua for making such a persuasive argument in support of the proposal. I agree with the core principles he articulated and certainly would advocate that as clinicians, our primary focus should be to concentrate on providing the best possible care for our patients. But in closing, let me emphasize 2 final points. First of all, value is not just a variable, it is an equation that is based on multiple factors that can be dependent or independent of one another, an equation that can be quantitative or can be calculated even qualitative, I suppose, imperfectly. So my point is that if we choose just to consider efficacy the best possible treatment, we're actually not calculating value since it's an independent factor. I think we need to be engaged in all possible factors related to value, which certainly includes cost. It's not something that we can give to the economists, the administrators, and the policymakers to calculate on their own. Secondly, when we deliver medical care, we do so on the historic foundation of knowledge that has come forth through the scientific method. But that foundation has already been highly influenced by issues regarding cost and many value calculations along the way. Basic and translational research, which has been competitively funded by the public sector, involves a value equation of not just great ideas, but financial budgets that are feasible to make the proposed projects move forward. In the private sector, R&D investment is based on a value equation not only of clinical impact, but also favorable recovery of costs. Even the clinical trials that define our standard of care are based on determinations of scale and scope by economic considerations of which trials are possible or to do based on finances. So please understand that I think that best possible care is the most important emphasis as physicians, but that we can't excuse ourselves from the calculation of value, which includes cost and economic considerations. Thanks again.
Thank you very much, Dr. Callister. I do wish that he could be here with us. He's probably transiting in some international airport now, heading back to the States from Guangzhou. But we have Dr. Chua online. And I think before we open up to questions from the floor or comments, perhaps Dr. Chua, you may want to have say a few words about your response, as well as how you feel the debate has opened up issues on both sides. So first, as the proposition, and then after that, as a fair-minded individual.
Yeah, I guess the very fact that I'm the proposition means that I have to support the motion. As I said, where you stand is where you sit. So at this juncture, I'm sitting on the proposition side. So that's how I have to go to debate and prove my point. But the fact of the matter is I totally agree with Callister that, we have to be involved. But I think the ultimate question in everybody's mind is who is going to pay for the treatment? I think that will depend on many other factors, like, for example, the larger the economic pie a country has, the more likely you're going to be able to provide more expensive treatment to people. We're talking about the GDP of the country. So the larger the pie, the more likely. So in Singapore, we're only spending 6%. The States, it's 17%. The question is, if we move to that sort of level, GDP, will we be able to provide more of these expensive stuff? The second thing is, of course, government foresight and legislature. That means they are really preparing to increase the costs in healthcare spending as well. So you have all your Medisave, Medishield, and American Medicaid to provide for the financing. The third is, of course, taxation for provision of infrastructure, and you can put it the other way around, cut the doctor's pay or something, so that you can have more money to buy more of this expensive stuff. And finally, of course, you have still insurance to come in and charity. So all these is going to provide the payment for your treatment. So that is what we're actually asking ultimately. Of course, healthcare economics will help to, at best, justify or distribute resources to its best places. But at worst, it just gives us an awareness.
Thank you, Dr. Chua. I suppose you started off from the perspective of the proposition, and then along the way, you morphed into a fair-minded individual, summarizing both ends of the spectrum.
Yep.
Correct?
Yep.
Now, maybe at the same time, you guys can keep your questions coming. I will refer to the chat soon. There's time, but not so much. So please put down your questions or comments over the next minute or so. Then we can talk for another 2 to 3 minutes before we move on. So if I may summarize, there was this book written by politicians, by a senior politician, S. Jayakumar. He called his book Be at the Table or Be on the Menu. So to a certain extent, Dr. Callister's point was that we as clinicians, if we want to join in the discussion, we need to be at the table. Otherwise, we will be on the menu. And I'm so glad that radiation oncologists have stepped up over the past decade. And I think more of us, or less of us, are on the menu anymore. And hopefully more of us can sit at the table and communicate. But having said that, I think Dr. Callister made a conclusion, which I'm not sure we were able to catch. But he said that institutions, governments, etc., should provide some guidance as to cost or value considerations. This is because I think the fair-minded approach in understanding the nuances as a whole is a very tall order that only mature and experienced clinicians will be able to have and to make the call. I can't imagine a newly minted attending or consultant struggling with communicating with patients and making treatment decisions, being confounded by yet another consideration. And the final point I want to make is about the holy or unholy trinity, the three P's, you know, the patient, the payer, and the provider. Right now, we are talking as if there is only two parties in this trinity, being the patient and the provider, but there is the payer. And the payer may be sometimes the one creating a lot of confusion because the payer wants to look good, promises the sky, whether you are talking about the government or the insurer who are attempting to attract people to buy their insurance plans, giving a higher premium, say, for example, to say that they provide proton therapy coverage. And then on the other hand, it is the provider who has to stand on the payer side to be the gatekeeper. So these things really confuse the matter, and I think the purpose of this debate was really to open these up. And I'm glad that both clinician, administrator, debaters shared the heart that clinicians should focus on translating the best science and technology in their clinical care first. Okay, so in terms of questions, Dr. Chu said, what would you write to insurance company to justify proton? Jeffrey was asking who should fund a health economist. Yeah, good question. And Dr. David Tan says text the bankers more. And Dr. Bala said, did we have so much debate when we transitioned from 3D to IMRT? All are good questions. I guess we all do know the answers to this. And I hope that this debate has opened up the issue so that all of us can understand what are the underlying currents at play. Now, I'm going to introduce an interesting segment into this debate. It is the polling function that we have in Zoom. There are no answers and there's no ultimate right and wrong, right? But now the poll is an opportunity for us to vote which side of the motion we are on, and we'll get the instant result within 30 seconds to 1 minute. So feel free, go with your free spirit and your instinct, okay? Clinicians should focus on translating the best science and technology to clinical practice and not be burdened by health economic considerations. Come, let's go. Are you proposition, opposition, or you're fair-minded? Don't think so much, just go. Hurry, 10 seconds, 20 seconds. Trust your instincts, go with your heart. Drink more cocktail. Okay, can we see the answers, please? Yeah, Jeffrey Doan, fair-minded means it's a nice way of talking about people who cannot make up their mind. Sit on the fence. Okay. Wow. So we have 40% who oppose, which means that they believe that clinicians should participate in health economic considerations. And then I'm glad, it's amazing that everyone has taken a stand, or the majority have taken a stand, 74% have taken a stand. I'm not saying that the 26% haven't took a stand, but I suppose they understand both sides of the debate. That is great, thank you very much. And this is information that is just going to be kept within here. Now, we didn't do the poll for the first motion. Maybe we should do it now, just for our own information as well. Proton therapy will be the new standard of radiation care in the future. Nobody says anything about the timeline here, 10 years, 20 years, a century, whatever. Go with your heart and your instinct. Come, let us know what you think. Oops, polling not start or end. You want to try again, controller? Can you bring up the poll? The debate, the poll for the first motion. Okay, it's up again. Let's try. Go with your heart and we'll see the answers. Can we flash out the answers, please? All right, it's interesting. So 52% of attendees here believe that proton therapy will be the new standard of radiation care in the future, without a timeline specific to this. And it's interesting. That's great. Let's all look forward to the day whereby the cost comes down and we can all, and the technology continues to improve, especially in image guidance and beam shaping, and we can all give the best treatment to our patients. Now, without further ado, I'll call a close to this debate. Thank you, Dr. Chua and Dr. Callister, for your wonderfully prepared speeches. I will now hand the time over to the MC.
An explosive entertainment for you. That was a beautiful rendition of Dynamite BTS. And again, that was a beautiful one. Ladies and gentlemen, you have selected that, and later on, you'll also have another chance to do so. But right now, let's go right back to the highlight of the evening, which is the final debate of the evening. For the final debate, we will have Dr. Jonathan Tay, who will be moderating the final debate. Ladies and gentlemen, I shall now pass the limelight over to Dr. Jonathan Tay for the final debate.
Good evening. So we now come to the third and final motion. There is still benefit in using protons in prostate cancer. Proton therapy was first used in prostate cancer more than 4 decades ago, but till now it remains a subject of some controversy amongst physicians, patients, and payers alike. And once the proton centers open here in the near future, the question of the benefit of using protons over other well-established radiotherapy modalities will become very real to us indeed. So thankfully, we have 2 world-renowned experts in prostate radiotherapy, Dr. Jason F. Statayu and Professor Peter Hoskin, to go hammer and tongs debating this motion. There's nothing like a good debate to focus our minds and clarify the issues. So for the proposition is Dr. Jason F. Statayu, who is Professor of Radiation Oncology at Harvard Medical School and Director of the GU Division in the Department of Radiation Oncology at Mass Gen Hospital. He's an internationally recognized leader in the field of GU malignancies and principal investigator of various multi-center trials in bladder and prostate cancer, including proton therapy. So let's begin the debate.
Thank you so much for allowing me to join your wonderful symposium. I will be talking in favor of the proposition there is still benefit in using protons for prostate cancer. So let's debate. Indeed, IMRT has completely replaced 3D conformal radiation, certainly in a short period in the United States. And that, by the way, all happened without a randomized controlled trial. And now we have proton therapy. And protons, well, they're in the crosshairs of controversy. With many claiming cost as the main limiting factor. Cost more, but is it worth more? Well, let's just look at what patients have to say. There is strong patient preference for proton therapy. In fact, it is the only cancer treatment with a fan club. And yes, books about protons for prostate cancer have been in the top 5 bestsellers on Amazon for over a decade. And patients are crisscrossing the United States in search of proton therapy. Some say we're living in a state of gizmo idolatry. Well, if we look at Gartner's hype cycle, when a new technique is introduced and a celebrity is treated, it goes through the peaks and troughs of being the best thing since sliced bread, I wouldn't give it to a dog, and eventually figuring out appropriate use. I would argue we have now reached that appropriate use sort of balance with protons for prostate cancer, and there is a role for protons in prostate cancer treatment. So let's look a little at the history, physics, and clinical potential here initially. First of all, it was in 1974 when the first prostate patient was treated with protons. And the FDA approved protons in 1988. So it is very important to know that this is not an investigational treatment. It's not new. IMRT is much, much newer and doesn't have as many decades of experience as does proton therapy. What about the physics? Well, that's clear. Look at these pristine Bragg peaks of selected energies that go to a certain depth and stop. Indeed, protons are particles that have charge and mass and therefore defined range in tissue. They contrast to photons, which continue to deposit dose beyond the target in tissue. So again, with protons, it covers the tumor with less entrance, less exit dose. And these principles are critical because radiation-related complications do not occur in unirradiated tissue. Normal tissue irradiation does not benefit the patient. One can optimize the therapeutic ratio by maximizing radiation dose to the tumor and minimizing normal tissue dose. Indeed, protons have gotten even better with spot scanning beams, scanning technology, or what's called intensity modulated proton therapy. So this dose deposition is even better defined. And what's the clinical potential of all of this? Well, lower integral dose and absence of exit dose leads to less toxicity and improved treatment tolerance and reduced late effects. If ever a picture was worth 1,000 words, here is a patient being treated with medulloblastoma. Look at protons avoiding all those anterior organs. Yes, there are accepted adult indications for skull-based tumors, eye tumors, spine and sacral tumors, and many other opportunities, including prostate cancer. It's an opportunity. So, do the physical advantages translate into measurable clinical benefit for common cancers such as prostate cancer? Well, that's the million-dollar question. And there is certainly data to suggest that the answer may be yes. And even more rigorous data is coming. So let's look at the data. Well, here are some plans. Which plan would you rather have? Look at this, all this extra dose with IMRT when treating the prostate and the pelvis compared to these beautiful proton plans. Indeed, if you minus the two plans out from one another, this is what you get. The target is treated to the same dose. So cure rate should be the same, but you have all this extra dose bath in the pelvis with photons compared to protons. In fact, that leads to liters of body excess volume tissue that is irradiated with IMRT compared to protons. If you look at DVHs, the green and the blue lines are proton plans, 3D conformal and IMPT protons compared to the red IMRT. Look at all this rectal dose sparing, especially in the low to moderate dose range with protons. In fact, IMPT allows partial prostate boosting and really, exciting future possibilities. Anterior beam fields with protons allows avoiding the hip joints and more of the rectum, especially if we use a hydrogel spacer. So lots of exciting future possibilities. So let's look at scatter dose. The further you get away from the target, there is far less scatter with protons compared to photons. And this leads to less risk of radiation-associated second cancers, both in field and out of field. There's about a 1/3 reduction in second cancer risk with protons. And that's been proven in clinical cohorts such as this one from MGH. Now let's look at my opponent, Peter Hoskin. He is a co-author on this paper. Even he said, proton planning studies suggest very low second cancer risks. Until there is sufficient clinical evidence regarding second cancer risks associated with modern irradiation techniques, the data produced from planning studies is relevant when considering which patients to irradiate and which technique to employ. And in fact, there is clinical evidence now too. So he's totally in my camp as well. When we look at clinical data, such as patient-reported outcomes in some clinical cohorts, there's less GI acute toxicity with protons. There is also less GU toxicity in some population-based studies. In fact, other population-based studies suggest both less acute and late GU and sexual toxicity. We are generating the rigorous data, however. Yes, and it's happening in prostate cancer. And you can't run a randomized phase 3 trial of protons versus photons if there isn't at least equipoise. And yes, the particle trial is that randomized phase 3 trial of 450 men, protons versus IMRT, with quality of life outcome, primary outcomes. And this trial, very exciting to announce that in November 2021, fully accrued 450 participants. There's also a companion registry for over 760 patients on the study. So the definitive answer is coming. And this is how many of us feel as we await those results. So in conclusion, proton therapy is safe, effective treatment. It's not investigational, and it has some physical dosimetric advantages over IMRT. It can spare normal tissues and avoid the lower dose radiation path. It can decrease integral dose, which can lead to lower rates of second cancers, especially in younger men. Proton therapy outcomes are at least as effective as alternative radiation modalities as per those retrospective studies, but the rigorous randomized controlled data is coming soon, and clinical trials must be supported to fully realize the potential of proton therapy. The cost of building proton therapies is decreasing. We need to promote scientific innovation and creativity while looking to decrease cost and maximize efficiency further. We need proton therapy, ideally geographically well distributed for access, with an emphasis on evidence development and decreasing access disparities. So let me leave you with this thought. Never trust atoms. They make up everything. And to my opponent, well, he is wrong, but I am actually Canadian, and I agree with everything he is saying as well. Thank you for your attention. Thank you.
Right. That was an energetic exposition on the potential benefit of protons in prostate cancer, which may have persuaded a number of us. But let's hear from the other side first, before coming to any premature conclusions. Professor Peter Hoskin is no stranger to many of us. He's now Professor of Clinical Oncology in the University of Manchester and Honorary Consultant in Clinical Oncology at the Christie Hospital, Manchester, as well as University College Hospital, London. In Manchester, he leads the radiotherapy-related research group and is currently the clinical editor for the Green Journal. He will now present the opposition's case.
Thank you for inviting me to take part in this debate at your annual dinner. I'm really sorry I can't be there to share the dinner with you. And the title is There is Still Benefit in Using Protons in Prostate Cancer. But of course, that's the title. I'm against the title. There isn't. So what is the case? Well, I've nothing against protons. I work part of the time in Manchester, and just down the road, there's this blue plaque, and that is for Ernest Rutherford, who discovered protons in the laboratory you see on the left. That's a current photograph in the Rutherford laboratory using the equipment on the right, which, as you'll see, is somewhat rudimentary, but nonetheless enabled him to identify atomic particles. And indeed, in Manchester, we have the UK's only active proton center at the moment, opened 3 years ago, the Christie Proton Center. So I have nothing against protons. They are useful in their place, but their place is not prostate cancer. So what has happened over the last 100 years or more since they were discovered? Well, for protons, there's 90 proton centers worldwide. That certainly wouldn't be enough to treat all the prostate cancer in the world. 37 of them are in the US. And they're used for highly selected, mainly pediatric indications. But there's no level 1 evidence for any of that activity. And there's no mention in prostate standard of care guidelines of protons as standard of care. Contrast that with photons of whatever type you like, whether it's modern IMRT VMAT, whether it's brachytherapy, whether it's SBRT. They are available in virtually every cancer center worldwide, and they are the standard of care for prostate cancer. And why is that? Because there is extensive level 1 evidence to support their use. But they both started out together. They both started out round about the beginning of the 20th century. So is there something wrong with protons? Well, it took them 50 years to be used clinically, and that was in neurosurgery and treatment of pituitary tumors. And even then, the efficacy is not well documented. First treatment center at Loma Lindy was opened in 1990, and that was the first high-energy proton facility available to treat deeper tumors. And currently, it has minor applications in pediatric and CNS tumors and choroidal melanomas. In contrast, photons, early use, shortly after the discovery of them, standardized methodology for delivery within 10 or 20 years, early major impacts in common tumors, seeing regression of cancers in the skin, in the breast, and the cervix was really dramatic. And as time evolved, they became more technologically adept at recognizing and addressing complex volumes, organ motion, all the other problems we're familiar with and which we can now largely solve with the modern ways of delivering radiotherapy with VMAT, IGRT, IGBT, SBRT. I don't need to extend that for this audience, but none of that is available with protons. But the most compelling issue is the evidence base. For photons, we have an extensive evidence base with level 1 evidence, endless randomized controlled trials. For protons, it's negligible. In fact, there's very little at all. Let's look at it. This is a nice review produced by the Boston group. You see there at the top, the standard way of depicting a potential advantage for protons. On the left, the dose distribution from a proton beam. On the right, the fixed field IMRT distribution, showing a large low dose bath despite targeting the prostate in the center. But of course, that is not state-of-the-art photon delivery. We can do much better. Here we see on the left SBRT, a very much more conformal dose delivery than you get with protons and without the high dose going through the hips. On the right, brachytherapy. Brachytherapy, the most conformal way of delivering high dose radiation. You see there little or no dose outside the prostate gland. And then look at the data on there. Most of it is database data or non-randomized comparative data, because that's all there is. So this is low quality data. And this is as published in 2019. Not much has happened since then. And the story that protons may be less toxic, look, higher acute GI toxicity in one of those studies, higher late GI toxicity in 3 of them, and equivocal findings in another one. This is not compelling evidence to switch to protons. And the other thing is the business case. In the UK, the Proton Centre business case built a proton centre for £150 million. It cost 25.5 million to run it per year, and that's to treat 750 patients per year, of which 50% are thought to be research patients. Let's compare that with a modern linear accelerator. It costs about 2 million. So you can work out you can get over 70 of them for the price of a proton center. But if you add in an afterloader, well, that's only 0.25 million pounds. And each working to capacity will probably manage to treat about 4,000 patients per year. That is the cost of nearly 5 proton centers. So you can see that the sums just don't stack up. And there's a very nice study here from the US looking at the comparative cost effectiveness of laparoscopic prostatectomy, intensity modulated radiotherapy, and proton beam therapy. And the bottom line is protons are much more expensive. Here you see the Medicare reimbursement costs 32,000 against 18,000. You see in a Markov model looking at the societal costs, including impact on the patient's lifestyle and employment and so on. Protons turn out to be about 3 times as expensive as photons, and the cost per quality is 26,766. This data, of course, is not robust. And why is it not robust? Because, as you see on the bottom line there, the evidence to put into the model is very limited, particularly in terms of cancer control and quality of life. But that's what we need to know to decide whether to use protons or not. So the debate is, there is still benefit in using protons in prostate cancer. Well, I think I've shown you there is no benefit at all. There never was a benefit. There is still no benefit. Despite over 100 years of trying, protons still have to find a place in prostate cancer, and there is still no robust evidence. So my view is that protons for prostate cancer at least are destined for the scrap heap. They're in good company, as you see at the bottom there. Concorde was a wonderful aeroplane, but not cost effective. Some of the others were perhaps not such good inventions. But in that line, I think we will soon be adding protons for prostate cancer. And there I will close my argument.
Professor Hoskin has authoritatively argued the current lack of high-level evidence for protons in prostate. And now Dr. F. Satayu has the first right of reply. So let's listen.
I appreciate all the good points my esteemed colleague, Professor Hoskin, has made, but he is misguided. This debate is not whether protons are superior, it's whether there's still benefit in using protons for prostate cancer. And as I have to bring this up again, as he wrote, protons and brachy-planning studies suggest very low second cancer risks. And until there's more data, the data produced from planning studies is relevant. He's right. And by the way, not all patients are candidates for brachytherapy, as everyone well knows. So protons have a role. And yes, unlike what he said, there is actual data about second malignancy risk. This is a matched cohort study with 1,450 proton patients, median age 56. Look at that hazard ratio in favor of protons in terms of avoiding second cancers. And this age range is relevant to the prostate cancer population. He loves to show my paper, and I appreciate that. Thank you, Professor Hoskin, because if he actually looked at the table carefully and he added up all the arrows going down, suggesting benefit to protons, it's 5 against 4 compared to photons. Protons win. At least there's equipoise, and there could be potential benefits, so there may still be benefit. Cost, yes, of course he's going to talk about cost, but once you add IGRT, cone beam, CT, brachytherapy to photons, the relative cost of protons is not that big a deal, and certainly a spit in the bucket compared to current systemic therapy options. And as we all know, as technology matures, cost goes down. Look at what's happened to computers and to cell phones. And this is what's happened to protons over the years. Do you think so many proton centers would be popping up around the world if it were a bad business model? And yes, of course, he brings up Concord and parallels it to proton therapy, saying they're in the scrap heap. Clearly, Professor Hoskins is not reading the news. United Airlines has revived Concorde. It's traveling twice as fast as modern airliners. Similar to proton therapy, Concorde has figured out how to be cost effective. So in rebuttal, protons are not experimental. There is long-term clinical data on cancer control and quality of life. It has exquisite dosimetry. The decreased integral dose second cancer risk is real and relevant, especially in younger men. Clinical trials have been done and will fully realize the potential of protons, and there's many exciting new developments, pencil beam scanning, image guidance, even stereotactic body proton therapy, which will always be better than SBRT with photons. The cost of building proton centers is decreasing, the efficiency is increasing, and reference pricing is an option. So you must agree with the motion that there is still benefit, some benefit, in using protons for prostate cancer. Thank you.
Looks like things are heating up with Dr. Efstathiou's high-octane rebuttal. Professor Hoskin will now say his piece.
Thank you. It's a great pleasure and privilege to be debating with Professor Efstathiou, whose identity I did not know when I prepared my earlier talk, and indeed quoted one of his papers showing a characteristically eloquent description of the higher toxicities reported with protons. His arguments, of course, rehearse those which are incontrovertible and relate to the physics of proton beam distribution compared to a single photon beam distribution. Carefully, however, he avoids comparing highly conformal photon distributions such as VMAT or SBRT, and inevitably, since it represents the most focused conformal dose delivery possible, no mention at all of comparison with brachytherapy, the ultimate conformal photon delivery. And for obvious reasons, in that there are clearly vastly superior distributions to protons obtained with SBRT and brachytherapy, as I showed in my previous talk. Furthermore, this is highly relevant to prostate cancer, unlike medulloblastoma, which I believe was his illustration. He graciously admits that there is no prospective level 1 evidence for protons, unlike photons, but promises more rigorous data in the future, which is good news. But then I gather that's from a single trial of less than 500 randomized patients. Compare this with the photon fractionation studies of recent years, where we have many thousands, if not 10,000s of patients, all randomized, all rigorously treated and followed up, and then contemplate the statistical power with which one might generate the role of protons in prostate cancer. Now, the only clinical data he did mention was that for second malignancies, and I am gratified to think he's read in detail one of our papers. This was, of course, based on clinical data, but clinical data in relation to photon treatment, not proton treatment. And that treatment was delivered some time ago using outmoded techniques. There is, for obvious reasons, no robust data on second malignancies after protons. Understandably, he claims there will be less, but no, there is an entry beam and there is an exit dose with protons. And modeling studies suggest it will not be zero. Indeed, only one modality has been shown to have no excess second malignancy incidence when treating prostate cancer, and that uses photons. And that, of course, is brachytherapy. And so, the case for proton therapy to be superior to photon therapy in prostate cancer has a long way to go yet to be proven.
Wow, with those stunning riposts from both sides, will the motion stand or fall? There is now an opportunity for you, the floor, to put in your quick-fire questions regarding the motion in the chat box, which I will then read out. Dr. Efstathiou is present live, but unfortunately, as Professor Hoskin is not available, he's kindly agreed to answer questions on both sides of the debate. But before that, since he's here, I'll first give him an opportunity to have the last word over Professor Hoskin and give him a couple of minutes to respond to the rebuttal. So while he's doing that, please enter your questions. So Dr. Efstathiou, please.
Sure, it's a pleasure to be here and fun to debate Professor Hoskin. Sorry that he couldn't be here as well. I mean, I think it's very clear that I won the debate. I have to make Two disclaimers though. Number one, I treat patients with both protons and photons. And number two, I'm the principal investigator of the particle randomized trial of protons versus photons. So I truly do have equipoise to this question. And I think there are strong arguments on both sides of the coin. There was something in the chat about the results of the particle trial coming in 5 years. That's actually not true. The particle trial fully accrued in November of this year, and results will be available in 2 years. It is a 2-year primary endpoint, and it's a patient-reported quality of life trial. And you're going to see lots of robust evidence. I also saw in the chat there questions about the rectal spacer. Absolutely, the rectal spacer is fantastic, and there's trials showing less rectal toxicity. And so what's the added value of protons? Well, we'll see, because the particle trial actually stratified patients by use of rectal spacer or not, and it stratified patients by use of moderate hypofractionation versus conventional fractionation. We're going to get all those answers from that trial, but I would just say that the potential benefits of protons don't just lie in rectal toxicity, right? And I think if you really think about it, is there still benefit? It doesn't define how much benefit, but in certain situations, young patients, where you do want to decrease the very rare possibility of second cancers, I think the data is pretty clear that protons offer that potential. And although that's very hard to prove, because you have to follow tens of thousands of patients for decades, if you just think about that one point, you would probably convince yourself that there is still potential benefit to proton therapy. And I think I also highlighted in the talk all the new advances: anterior beams, pencil beam scanning, INPT, all of that. In some ways, protons has been lagging behind photons, right? The introduction of in-room cone beam CT, the introduction of pencil beam scanning has always been a little behind photons. But I think once protons catch up, again, there is exquisite dosimetry, and I think there's the hope for possible benefit. The last thing I'll say is cost. Yeah, of course, cost is always brought up, but Professor Hoskin was misguided in the way he showed that. I mean, he said 150 million pounds for every. That's for a multi-room, multi-gantry facility, and he compared it to a $2 million, Linac. That's not a fair comparison. Number one. Number two, I don't know where he's getting those cheap Linacs. Good Linacs these days are at least 4 to 5 million. But the point is, nowadays you can get single room proton centers for 25 to 30 million, right? And pricing is totally artificial, certainly in the US. And I think you're seeing a trend towards what's called reference pricing, meaning if there's a diagnosis of prostate cancer, you can treat with protons or photons, you'll get paid the same, okay? And then allow centers to make the decision whether or not they want to invest in such centers. I think proton therapy is a great opportunity for generation of philanthropy into oncology, to help build those centers, and then introduce proton therapy into practice. And with that, I'll just I'll leave it to the discussion and questions.
Thank you, Dr. Sathu. There's a question from Jeffrey asking about what about locally advanced prostate cancer requiring pelvic lymph node radiotherapy and boost? And he proposed the interesting idea of proton to the pelvis, but with brachy and SPRT boost. I wonder what your opinion is on that. Would that be something that is attractive?
Yeah, I think most of the data in prostate cancer is in treating an intact prostate only basically fields. But there's lots of interesting planning, and I showed a picture of it in the talk of treating the pelvis as well. And you see the avoidance of this whole low to moderate dose bath with protons. So I think there is a role for treating the pelvis with protons. I think absolutely for local therapy, you could combine it with brachytherapy, and the dosimetry of brachytherapy is certainly exquisite. Not all patients are candidates for brachytherapy. We all know that, right? So certainly there's still roles for using proton therapy to treat the prostate. But I think that you raise, there's also work looking at using protons in the post-op setting, right? And there's some studies that have started to look at that. Do remember, when you demand level 1 evidence, randomized controlled data, you need to have had a a critical mass of proton centers available internationally, nationally, to generate that kind of drug, right? So 15 years ago, you couldn't run these trials. So we have been doing that now. It's been happening in a lot of different disease sites with proton therapy, but it sort of couldn't happen until now, until there was that critical mass of proton centers to be able to properly accrue to well-designed trials. So don't be swayed by, oh, there's no level 1 evidence. Of course there's no level 1 evidence. There wasn't the ability to generate that, but now the trials have been done.
Okay, I think we'll just have one last question from Daniel. He asked, in your opinion, what level of proton technology is minimal for prostate in this current era? For example, is the minimum, proton PET beam scanning? What level of onboard imaging do we need? Yeah. So what are your thoughts on that?
Yeah, I think that it's a great question. I mean, it depends on how proton centers are being set up. If you're developing a national proton center, or there's clear regional kind of government-based, funded centers, versus are you building in private centers a single treatment unit? Okay, so I think it does, what model is being followed to build matters. But these days, if I were, for example, a single center that wanted to bring in protons, I would probably invest in a single room center, and I would pack it with modern technology. Absolutely pencil beam scanning, and absolutely in-room imaging, in-room CT, cone beam CT capability. There's no doubt about that. The smaller the spot size, the better the plan. And one of the big ways that protons have always lagged behind photons is the lack of as good image guidance. Nowadays, that is available with in-room CT for protons.
Okay, thank you so much for your wise words, Dr. F. So let's now poll the floor to see what everyone thinks about the motion. So again, there are 3 options for the proposition, for the opposition, and finally neutral or fair-minded. So lock in your votes now. Wow. So almost 70% for the proposition. So I think we're going to see quite a few patients going on the proton machines when the proton machines come online in Singapore. So with that conclusion, I draw a close to this debate. I would like to thank Dr. F. and Professor Hoskin for that very spirited last debate. I hope it was as enlightening for you as it was for me. The grand proton therapy debate is now over, and I'll now hand over the time to the MC for the night.